All sodium problems cause symptoms in the CNS. All sodium problems cause symptoms in the CNS. In other words, when you have high sodium, it causes CNS, like seizures and confusion. And when you have a low sodium, it causes symptoms in the CNS like seizures and confusions. If you bring down, when you correct it too fast, you cause a seizure because you cause cerebral edema. You cause cerebral edema, and it causes seizures, and the brain swells with the seizures. And that's why you have to bring it down slowly. Bring it down slowly. You have to bring it down slowly, because if you bring it down too quickly, you'll see what ends up happening is, if this is a bloodstream and these are the cells in the brain, and the cells in the brain have this very super high sodium level, and you have all of this sodium here inside the cells, but you bring it too low here, the sodium level too low, what ends up happening is that the cells swell. They start to pull up water. Because when the blood level of sodium goes down too low too fast, the cells swell, and that causes a seizure, confusion, and all symptoms of sodium are CNS. High sodium is a symptom of the CNS. Low sodium is a symptom of the CNS. Correcting the sodium down too quickly is a sodium correction too quickly, is a CNS and a seizure and a swelling. And if you bring the sodium up too quickly, you melt your ponds. When you correct the level of sodium up too quickly, you cause central pontine myelinolysis, and the myelin melts, central pontine myelinolysis, and it melts. So high sodium is CNS and low sodium is CNS, the symptoms of a seizure. She sells sodium seizures by the seashore. Yeah. So low sodium has several etiologies. You have hypervolemic. You have hypovolemic. Your volume depleted. You're dry. You have hypervolemic. You're edematous. Hypervolemic causes of hyponatremia is cirrhotic, nephrotic, and CHF. Cirrhotic, nephrotic, and CHF. Cirrhotic, nephrotic, and CHF. Cirrhotic, nephrotic, and CHF. That's hypervolemic. These are people that have intravascular volume depletion. The vascular volume is low. The vascular volume is low, and the body perceives it's like you're going to die. So what ends up happening is, like, the carotid body starts saying, oh my God, your volume depleted. Holy shit, we got no perfusion pressure. We're going to die. And it sends a message up to your hypothalamus, hey man, we need more ADH. And so what ends up happening is that you get a big increase in ADH. Well, what's the difference about that and the disease called SIADH? Because this isn't inappropriate. It's the appropriate increase in ADH. You increase ADH to try and increase volume, because you have a heart that beats like this. And you need perfusion pressure. Cirrhotic and nephrotic, low albumin. Cirrhotic and nephrotic, intravascular volume depletion. Cirrhosis and nephrotic syndrome, intravascular volume depletion because of low albumin, and your body needs perfusion pressure, so it increases ADH to try and increase the volume. And why it does that? When you have a problem with volume versus sodium level, which one is more critical to the body? Perfusion pressure or sodium level? Which one of those is more critical to the body? Perfusion pressure or sodium level? Perfusion pressure is more critical to the human body. Which one is more critical? Perfusion. And that's why when you have cirrhotic, nephrotic, CHF, and the body perceives it as hypovolemia, as insufficient perfusion pressure. You sense it in your carotid body, and it sends a signal up to your hypothalamus to secrete more ADH. But your sodium goes down, but your perfusion is normal. Now, low volume states where you're dry. This is where you sweat, but you're replaced with free water. You urinate, but you're replaced with free water. GI tract, but you're replaced with free water. Now, remember that a few minutes ago in the hyponatremia section, we said that sweating and urine and GI losses results in hyponatremia. Of course it does, because you're dried out, you're dehydrated, you're hypovolemic, you're like a salty pretzel that's been left out in the sun. We're born as grapes, we die as raisins. That's true. Babies are the juiciest, so tasty, so nice, little juicy babies. 75% body water. But when you dry out like this and then you drink water, this goes with drinking free water. Grandma is on a diuretic. She urinates out a little salt and a lot of water, but she replaces only with free water. She urinates out a little salt and a lot of water, but she replaces only free water. And eventually, Grandma drives her sodium level down. Grandma drives her sodium level down, and that's why you can get hypovolemic hyponatremia. The answer to these is correct the underlying cause. The other one of this is adrenal insufficiency, Addison's disease. Addison's disease does not need to replace with free water. Addison's disease is insufficient aldosterone. Addison's disease is insufficient aldosterone. And when you have no aldosterone, aldosterone, my favorite hormone, makes you retain sodium and excrete hydrogens. Retain sodium and excrete potassium. So if you don't have aldosterone, you're not retaining sodium. You're losing sodium. When you don't have aldosterone, you're losing sodium. And that's why Addison's disease is a cause of hypovolemic hyponatremia, because you're simply aldosterone deficient. And the treatment for that is to correct the cause, to give steroids or fludrocortisone, because fludrocortisone is the closest thing you get to giving aldosterone. Okay? All right, now we are down to euvolemic, and eu is the word, the Greek word for good, true, or normal. Euvolemic is the Greek word for good, true, or normal. And good, true, and normal hypovolemia, hyponatremia is pseudo-hyponatremia, psychogenic polydipsia, SIADH. Pseudo-hyponatremia, psychogenic polydipsia, and SIADH. Pseudo-psycho, SIADH. Now, pseudo-hyponatremia is when you have a huge increase in glucose, driving your sodium down artificially. For every increase in 100 of your glucose, there is a 1.6 drop in sodium level. Now, this is a memorized fact. It's a memorizable, important, tested fact that you know that every single person who's got a sugar of 7, 8, 900, everybody who's got a sugar very much above normal, for every 100 points above normal, the sodium will be down simply because of the hyperglycemia. It's not real. Fix the glucose. It's not real. Fix the glucose. It's not real. Fix the glucose. Pseudo-hyponatremia. Now, whether one source that you read says a glucose of 100 for 1.4 or 100 for 1.6 is not really that important. I get these people, it's only a relationship of 1.4, 1.5, 1.6. Whatever, whatever is close enough. The point is that when you have something like non-ketotic hyperosmolar syndrome, when you have people have non-ketotic hyperosmolar coma and they have these glucoses of 1,500 and you go, holy shit, man, why is their sodium down? Because the glucose level It's driving down the sodium. Because the glucose level is driving down the sodium, that's why. So, pseudo-hyponatremia, psychogenic polydipsia. Psychogenic polydipsia, you're manic, you're drinking, but the volume status is normal. You're not edematous, you don't have Ralls, you don't have edema, you don't have an S3 gallop. Pseudo-hyponatremia is from glucose. Psychogenic polydipsia is from drinking an awful lot. And SIADH. Okay. Now, that's the hardest one. So, if you think that you will understand SIADH on one time through, you are crazy. SIADH is a very difficult subject for people. Most people never get it, honestly. They never understand it. They never figure it out. And they spend the rest of their life managing SIADH with this simple treatment. Consult nephrology. Nephrologists don't want you to understand it because their answer would be, who will consult me? And SIADH is probably the only thing in nephrology for which there's been anything new in the last 10 years because we have new treatments. Now, thyroid disease also has an effect on free water, and people who have low thyroid have a hard time clearing free water. The etiology of that is not clear. It's not understood. Why is it that hypothyroidism is associated with a decreased ability to clear free water? It's not clear. It's not understood. Why do you have a decreased ability to clear free water? I don't know. I don't know. I don't know. It's not clear. But you do. You just have to know it as a fact. And I hate to do this stuff where you have to memorize. I hate just memorization. Low thyroid causes hyponatremia. Low thyroid causes hyponatremia. Why? Because it does. Why? Because you can't clear free water. Why? Because it's got normal volume status. Why? Because it does. Well, that's not very easy to memorize. It's not. Change the world. Change facts. I don't even like division. Why do we have division? I only want addition and subtraction. Multiplication I can handle, but division I can't stand it. Square roots make me have a seizure. Maybe we should just eliminate it. Okay, avoid it. You can't avoid it. Low thyroid causes hyponatremia. As they say in Russia. Why do I have to learn this? In Russia they say, Tavshitsky. Learn it. SIADH. SIADH. What inside the brain can cause SIADH? Stroke, tumor, subdural, epidural, subarachnoid hemorrhage, sperm emboli, dinosaur bites. Anything in the brain can cause SIADH. Stroke, tumor, trauma, hypoxia, subdural, epidural, subarachnoid hemorrhage. What inside the lung can cause SIADH? No doubt when I ask this, medical students always say, small cell cancer, oat cell cancer, small cell cancer, oat cell, yes, small cell, oat cell, small cell, oat cell, oat cell, oat cell. Okay, what else inside the lung? Pneumonia can cause SIADH. What else? Tuberculosis, pneumothorax, atelectasis, tuberculosis, sarcoidosis, anything. Anything inside the lung. Anything in the lung, anything in the brain. Anything in the lung. Not just small cell cancer, troops, any lung cancer. And when I ask people what kind of pneumonia does it, Legionella certainly does it. Legionella certainly causes hyponatremia and SIADH. But any pneumonia, and this is hard, because why does something in the lung cause SIADH? What in the lung makes antidiuretic hormone? Plus, if you wanted me to learn it, you'd call it pro something. Why are you saying you're anti? Are you hungry? I'm anti starvation. Are you thirsty? I'm anti not drinking. Anti not drinking. That's what this sounds like. Crazy. Anything in the lung, any brain, medications and cancer. Any lung, any brain, drugs and cancer. Any lung, any brain, drugs and cancer. Any lung, any brain, medications and cancer. Yeah, anything in the lung, anything in the brain. All right, let's give you the easy part now. When you have a low serum sodium, if you had a low serum sodium, and you were normal, and you're a normal person, what should your urine sodium be, and what should your urine osmolality be? If you are a normal person and you had a low serum sodium, what is the normal response in urine sodium? You don't have sodium, what's the normal response? Because remember, serum osmolality is 2 times the sodium plus the glucose over 18 plus the blood urea nitrogen over 2.8, as if we couldn't say 3. Why do we have to do that? Because nephrologists are the only doctors with calculators. So when you have a low serum sodium, it's effectively the same thing as saying your serum osmolality is low. When you have a low serum sodium, your serum osmolality is low. So if you have a low serum sodium and your serum osmolality is therefore low, a normal person, would the urine osmolality be high or low if you had a low serum osmolality? For those of you who figured out on the first 8 times I asked, I regret that, but a lot of people just have a hard time with this. They really, really, really do. So you can feel special, you get it on the first time. I think it goes like this. If you're low serum sodium and you don't have sodium, the urine sodium should be low, less than 20, because I don't got sodium. Why am you pissing out the sodium? Are we supposed to urinate out the sodium and then bottle sodium from the Chinese? This, if you're Greek, I suppose. If you have no osmoles, you should not putting osmoles into the urine. So the short answer is that SIADH is a person that, despite the fact that they have a low serum sodium and a low serum osmolality, because serum osmolality is 2 times the sodium plus glucose, 18, plus BUN over 2.8. In a normal person with glucose is about 80. And BUN is about 10. In a normal person, serum osmolality is 2 times the sodium plus 10. 2 times the sodium plus 10. If your glucose and your BUN are normal, 2 times the sodium plus 10. If you don't have osmoles, you shouldn't be urinating out osmoles. And SIADH is a urine sodium that's inappropriately high and a urine osmolality that's inappropriately high. And that's why it's a disease. It's a disease because you don't have sodium and you don't have osmoles, yet you're urinating out sodium and osmoles. Wow. That's inappropriate. Now, let's go on to the treatment for a second and say, the therapy for SIADH, if all you have is a low sodium and no symptoms, you're not seizing, you're not confused, you're not disoriented, you're not obtunded, you're not lethargic, because all the symptoms of sodium disorders are of the CNS. A person like that you can manage by just restricting fluids. You can't manage them by giving sodium because SIADH is a water problem, not a sodium problem. But I want to be clear again, the management of SIADH is not the sodium level. It's not the sodium level. It's what is the nature of the symptoms. And if you have low sodium, no matter how low it is, if you're asymptomatic, just restrict fluids. It'll correct itself. Now, if you have more severe symptoms, if you're confused and disoriented, You can give saline and a diuretic. This is hard for people to understand. They go, I don't understand. I thought diuretics work by making you lose sodium. They do work by making you lose sodium, but you lose more free water. You lose more free water than you lose sodium. So you give saline, because that's giving salt and water, and a diuretic makes you pee out the sodium, pee out the water, and more free water. Now, if you've got severe symptoms, if you're seizing, obtunded, comatose, and it's very severe, then we can use conivaptan, tolvaptan. Conivaptan, tolvaptan, the Vaptans, which are drugs that inhibit ADH or 3% hypertonic saline. We don't bring it up too fast, because remember, what ends up happening if you bring up the sodium too fast? You bring up the sodium too fast, you melt your pons. You melt your brainstem and midbrain. So let's say this again. You have 3 types of hyponatremia. Hypervolemic, cirrhotic, nephrotic, and CEHF, cirrhotic, nephrotic, and CEHF, cirrhotic, nephrotic, and CHF. This is intravascular volume depletion. And what you do is, it's a person who basically wants perfusion pressure, so you get more ADH, and in order to maintain perfusion pressure, you end up blowing the sodium. Hypovolemic is people who are sweating and urinary loss, GI loss, and they can replace with free water. They urinate out a little salt and a lot of water, you replace with free water. They pee out and sweat out a little salt and a lot of water, they replace with free water. Correct the underlying cause. Euvolemic, which is the Greek word for good, true, or normal. Pseudo-psycho-SIADH. Pseudo-hyponatremia. For every 100 above normal, there's a 1.6 drop in the sodium. For every 100 above normal, there's a 1.6 drop in the sodium. Hypothyroidism does it because it does. SIADH. Anything in the brain can cause SIADH. Subdural, epidural, subarachnoid hemorrhage, meningitis, encephalitis, brain abscesses. Anything in the lung, not just small cell cancer, but adenocarcinoma, large cell carcinoma, pneumonia, TB, sarcoid, atelectasis, anything. Any lung, any brain, drugs in, cancer. Any lung, any brain, drugs in, cancer. If you had a low serum sodium, a normal response to a low serum sodium is a low urine sodium and a low urine osmolality, because you don't have sodium, you don't have osmoles. If you don't have a urine sodium, if you don't have sodium, you don't have osmoles. Why would you be pissing it off? SIADH is a person who's urinating out salt, urinating out osmoles when they don't have it. That's inappropriate. No matter how low the serum sodium is, if you don't have symptoms, it's managed by restricting fluids. If you're more confused, if you're more severely symptomatic, we can give salt, a diuretic, or you can block ADH at the kidney tubule with one of the Vaptans. Conivaptan and tolvaptan are ADH receptor antagonists, V2. Remember, V2 is at the tubule. V2 is at the tubule. V-tubule receptor, or hypertonic saline. Last itty bitty little point is SIADH is associated with a low uric acid, because uric acid is diluted out by all the extra free water that you absorb. SIADH is a hard disorder. It's hard. Remember that a normal person who does not have something like sodium should not be urinating it out. If you're spending sodium you don't have, if you're spending osmoles you don't have, it's a disease. Repetitive. If you get something like SIADH and understand this, on the 3rd time through, you're a genius. The average person needs 5 times.